A very good day to dear students. Today we will discuss about the drug-drug interactions. When we talk about the drug interactions, uh, what to say? We will discuss about the principles of drug interactions. What are the advantages and disadvantages of drug interactions? The mechanisms behind the drug interactions, and then we will see some examples. Drug-drug interactions occur, you know, when the you can say that pharmacological activity of a drug is being changed because of the presence of the other drug. Okay, it might be what to say, physical, chemical, physiological, kinetic, dynamic, whatever be it, it's called drug-drug interactions. And it should be also, clinically significant, because any two molecules inside the body are bound to interact, but most of the times it will be insignificant. So drug-drug interactions, we define drug interactions when the interactions are only clinically significant. When we talk about the drug interactions, one is the object drug, that is whose activity is affected by an interaction, and the precipitant drug which induces the drug interaction. So what are the various risk factors leading to the drug-drug interactions? Of course, use of multiple drugs, multiple prescribers. In the recent digitalized world, it is what to say, this multiple prescribers is not that big of an issue, but not very long ago, when the digitalization was not common, a prescriber will not be aware of the prescription from the other physicians. Okay. Classical example being, uh, congestive heart failure patient or coronary artery disease patient receiving low dose aspirin, going to an orthopedician for osteoarthritis who prescribes heavy dose of NSAIDs. They will nullify the effect of the low dose aspirin, but the orthopedician will not be aware of the prescriptions by the cardiologist. Anyways, extremes of age, of course, extremes of age will have certain physiological variations as compared to the typical adult, which will lead to drug interactions. And then of course genetics. Throughout your pharmacologic curriculum, you would have come across various examples wherein what is a variation in genetic expression will lead to variation in drug response, and it will cause drug interactions. And last but not the least, it is the illness, especially renal and hepatic dysfunction, because these are the two organs which metabolize and excrete the drugs. So the illness in these two systems will definitely cause drug interactions. What are the effects of drug interactions? The effects might be beneficial or adverse. When we talk about beneficial, it might be due to synergism and additive effects, and the combination can actually decrease the ADRs. But harmful is usually due to increased ADRs. Okay, right. It might be due to toxicity or loss of therapeutic effects by antagonism. So before going in further, we will talk about the three concepts of drug interaction: potentiation, or I would say four concepts: potentiation, additiveness, synergism, and antagonism. Okay. In potentiation, the drug A will not have any pharmacodynamic effect, but the presence of drug A will increase the pharmacodynamic effect of B. So that is potentiation. When we talk about synergism, the pharmacodynamic combined pharmacodynamic effect of A and B when given together will be more than the sum of the pharmacodynamic effects of A and B when given separately. Okay. Best example is being the combination when the antibiotics are given. Okay, especially when the antibiotics target different what to say mechanisms of cell metabolism or structural stability, that will lead to synergism. Antagonism is the combined effect of A and B when given together will be lesser than the sum of the effect of A and B when given separately. You can still see that the combination will have greater pharmacodynamic effects, just that it is reduced a little bit when compared to the individual drugs. And this is not desirable. This is actually desirable when it reduces the adverse drug reactions, but this is not desirable when it reduces the desired pharmacodynamic effect. And additive response, as the name suggests, the combined effect of A and B when given together is equal to the sum of the effect of A and B given separately. Then if you see this graph, we call it as isobologram to identify whether the drug interaction is synergistic or antagonistic or additive. Here you can see that on the x-axis we have dose of A and y-axis we have dose of B, and it is assumed that both the drugs have similar pharmacodynamic effect, and it is also assumed that the Emax of these two drugs are same. In this case, the ED50 of A and B is determined through various experiments and is marked on both the axes. ED50 of dose A is 100 and ED50 of dose B is say around 42 or 43. Okay, right? So what we will do is we will combine the different doses of drugs such that you can say that the effect is equivalent of the half of Emax. Okay, for example, see, if that combination of A and B producing the half of Emax falls below the thick line, then that combination is synergistic. Here you can see that this 30-24 falls below this thick line, so this combination is synergistic, whereas this combination falls outside the thick line 40-30, and this combination is antagonistic, whereas this combination 50-21 is additive. Okay, this is just a hypothetical situation to explain to you. Okay, now what are the types of drug interactions? It might be due to drug-drug interactions or drug-food interactions or drug lab test interactions or drug-disease interactions, but here we will focus only on drug-drug interactions. What are the various mechanisms of drug interactions? Might be pharmaceutical interactions, pharmacokinetic interactions, or pharmacodynamic interactions. Let us talk about the pharmaceutical interactions. The first is due to physiochemical interaction. Okay, for example, when you mix penicillin and aminoglycoside together, somehow the what to say, the drugs will be degraded and it will not have any desirable pharmacodynamic effect, and this interaction occurs outside the body. The same happens with ampicillin and dextran. We should not mix these two agents. Pharmacokinetic interactions might be at various steps, might be due to absorption interactions, distribution interactions, metabolism interactions, and excretion interactions. So when we talk about the absorption interactions, okay, classical example being antacids and tetracycline. Antacids will bind to tetracycline and will reduce the absorption of tetracycline. Then we have phenobarbital and antacid interaction. Okay, it will cause delayed absorption of phenobarbital. Then certain drugs which can increase the gastric motility will can decrease the drug absorption because it will reduce the time of the drug's presence in the absorption surface. And also the gastrointestinal microflora, which is present in the colon, is helpful for absorbing certain drugs, and when that flora is destroyed classically with the use of antibiotics, it will cause decreased absorption of certain drugs. Okay, right. Then we will now discuss about the distribution interactions. Classical example being warfarin and phenylbutazone. So displacement of warfarin from albumin by phenylbutazone will increase the free warfarin in the plasma, and thereby it will increase the anticoagulant effect of warfarin. Metabolism interactions might be due to enzyme induction or enzyme inhibition. Okay, so when we talk about enzyme induction, so these are the list of common enzymes which are responsible for metabolizing the drugs, that is CYP1A2, CYP2C19, CYP2C9, CYP2D6, CYP2E1 and CYP3A4, among which the most important is CYP3A4, which is known to metabolize almost 80 to 85% of the drugs administered. Classical example being warfarin and phenobarbital. Phenobarbital is an enzyme inducer which induces CYP3A4 and will reduce the metabolism, or increase the metabolism of warfarin and reduce the anticoagulant effect. When we talk about inhibition, the example being phenytoin and isoniazid. The isoniazid being the enzyme inhibitor, it will prolong the presence of phenytoin in the blood and it might lead to toxicity of phenytoin. A little note about the CYP450 family, which are monooxygenase enzymes, usually cause the phase 1 metabolism. It might be either mitochondrial or microsomal. It's present in both the places. Okay. Right. Some examples of CYP3A4 inhibitors are, protease inhibitors like ritonavir, indinavir, nelfinavir, saquinavir. Macrolide antibiotics such as clarithromycin, clarithromycin, chloramphenicol. Some azole antifungals such as ketoconazole and itraconazole, and nafazolone, cobicistat. Some CYP3A4 inducers are anticonvulsants and mood stabilizers like carbamazepine, phenytoin, oxcarbazepine, topiramate, barbiturates like phenobarbital, and some bactericidals like rifampin and rifabutin. Non-nucleoside reverse transcriptase inhibitors like efavirenz, nevirapine, hypoglycemics such as pioglitazone and troglitazone, glucocorticoids and modafinil, they're all CYP3A4 inducers. Excretion interactions might be due to alteration in renal blood flow or alteration in urine pH or changes in active tubular secretion, changes in biliary excretion and forced diuresis. Okay. For example of alteration in renal blood flow being NSAIDs will cause prostaglandin synthesis inhibition, and that will lead to complex interaction regarding to lithium excretion, Basically, the combination will reduce the excretion of lithium. Alteration in urine pH. Methenamine can alter the urine pH and precipitate the sulfonamides and lead to the development of crystalluria. This you all know very well, that is probenecid and penicillin. Probenecid will inhibit the binding of penicillin in the secretion site and thereby will increase the blood levels of penicillins. Changes in biliary excretion. It's something like indirect interaction, wherein antibiotics will clear the gastrointestinal microflora, and gastrointestinal microflora is essential for enterohepatic circulation of oral contraceptives. When the gastrointestinal flora is eliminated by antibiotics, the enterohepatic circulation is prevented, thereby affecting the biliary excretion or thereby increasing the biliary excretion of oral contraceptives, thereby causing a loss of efficacy of oral contraceptives. If you have seen about pharmacokinetic interactions, pharmacodynamic interactions are of two types, antagonisms and synergism. It's very similar to what we saw before, but you can see that here the drugs do not have similar mechanism of action or pharmacodynamic effect when we talk about antagonism. No, I will not say they do not have similar mechanism of action. I will say that they do not have similar pharmacodynamic effect. For example, acetylcholine and norepinephrine at heart. Then we have synergism, wherein two drugs combine with each other and produce a greater response compared to the response by the drugs when given alone. Okay. We will talk about some examples regarding the drug interactions. When amoxicillin and tetracycline will clear the gastrointestinal flora and will reduce the efficacy of oral contraceptives. Again, antibiotics will clear the gastrointestinal flora and thereby will decrease the vitamin K synthesis. Okay, so it can lead to anticoagulant toxicity. Furosemide and cause enhanced vestibular toxicity when combined with minocycline, aminoglycosides and antibiotics. Diuretics can cause hypokalemia and hypokalemia can cause digoxin toxicity. Aspirin and NSAIDs can cause decreased prostaglandin production and thereby reduce the pharmacodynamic effect of ACE inhibitors, beta blockers and thiazide-diuretics, because prostaglandins play a major role in the physiology of kidneys. Okay, when the prostaglandins are eliminated from the kidneys, then these drugs cannot function normally. Similarly, aspirin and other NSAIDs reduce the diuretic action of furosemide by reducing the prostaglandin synthesis. That's all about drug interactions. Thank you.